So today I will be discussing how we admit a patient and get them prepped for surgery and get all their medical records. So here at our specialty and emergency clinic, when you walk through the door, you're going to start out with a new client information form. So this has already got some of my information on it, but it's going to ask how you heard about us, owner's information, and then the pet's information. So if we didn't already have that in there, they would handwrite in the name, the breed, the age, the sex. So today I will be discussing Fredonia, who is a 4-year-old domestic short hair female spayed cat, presenting for a foreign body who would be admitted and getting hospitalized here with surgery. So from there, once we get this form, sometimes some owners will bring in records with them. Other times we do have to call the clinic that they would normally see if they're open during those hours. So what we would do is we would access the patient's chart here, and we would go down here to documents. And this patient doesn't have any documents uploaded, but whatever we would have gotten emailed over, or any test results from outside clinics, those would get uploaded up into documents, and we would pull their medical records from there. From that point, one of the technicians or assistants will go into the room, and we have their triage check-in form. So this goes over, you would initial their, who did the triage history, the doctor seeing them, presenting complaint, primary vet, and then the history. So we would get information like current medications, that's including supplements, preventions, any past medical information, so previous medications or medical complications like kidney disease, heart failure, heart murmur, things like that. And then from there, we're gonna get that TPR. So temperature, weight, pulse, respiration, if they're bright alert responsive or quiet alert responsive, their mucous membrane colors and capillary refill time, and then if an IV catheter is being placed. From that point, the doctor will go in and talk with the owners and then discuss what diagnostics they would like or medications. So the doctor would fill those in there, and that would give us what we would need to start to fill or complete. From that point, since the doctor is recommending a foreign body surgery for this patient, this form, we'd like to verify the client's name, address, phone number, the patient's name, and then the surgery that we are recommending. So because we also have a board certified surgeon here, we do have to offer this that offers the boarded surgeon to come in and complete that surgery, or the emergency doctor. Based off that, the doctor writes out specific risks for that surgery. That could be sepsis, damage to other organs, adhesions or scar tissue buildup on the incision site, reason for an NG tube or an esophagostomy tube, and that acknowledging that you're okay to have the ER doctor do that versus having Dr. Baker come in and start that procedure. From there, I get the owner's information about CPR, DNR, because that cat will be staying with us for a period of time. And while they are in our care, we have to know if their breathing or heart were to stop suddenly, if they would like her to be marked a DNR or a CPR. And a lot of times I do have to explain to clients the difference, but whatever they choose, that is how we proceed. When they go to their cage from there, they get a cage card with their name on it, their patient ID in our system, last name, and the owner's phone number. Red would indicate that that patient is a DNR, green indicates that that patient is a CPR. So even if they're sitting on IV fluids for 12 hours before we do that procedure, we know in case something happens, our ICU staff knows what that patient's code response is. We also have a variety of cards here as well. If that patient is a caution, has a Band-Aid that needs to be removed, wear gloves, we put those on the cage as well to indicate what cautions we need to take. Before going into surgery, typically a doctor will fill this out. So it will have the date that we're going to perform that surgery on, the doctor's initials, the technician doing the procedure, the name of the procedure, and the patient's code status along with weight. From there, they check mark sedation or anesthesia, if they would like an IV catheter, their fluids, what they would like their fluid rate to be, what type of fluids, so LRS, saline, isolite, and then their rate and their bolus rate in surgery. That we are going to intubate. Once I intubate, I'll mark the size down, and then pre-op blood work. So here we'll do a pre-surgical, a NOVA, and a CBC. And then after that, doctor will write out the drug protocols. So what the pre-med's going to be, what we're going to induct with. Typically here, it's going to be propofol or alfaxin, and then post-op, intra-op medications. So with a surgery like that, typically we would do cefazolin, and then post-op would be, if she had Dex as her pre-med, we would reverse with antecedent. Before starting to give any form of sedation, I would mark down her pre-op vitals. So what her temp is, her heart rate, respiration, mucous membrane color, and CRT. Because if something were to happen in surgery, I want to know what her pulses feel like, what her normal is, and then mark it for post. Regardless of the patient's status, CPR, DNR, every patient gets a emergency drug form filled out. So this has the pre-calculations. So we go into our Excel Word, we type in the patient's body weight, the name, and their code status. So this has CPR there, and then it comes up with drugs of a variety for what we would need, different bolus rates, or even joules if we needed to resuscitate. We have a checklist. So before we go into surgery, before we give any form of drugs, I'm going to check our primary oxygen source, our flow meters, our vaporizer, cuff and inflate those endotracheal tubes to make sure they will hold. Making sure that I have this emergency drug form and emergency equipment like a laryngoscope, extra ET tubes, monitoring equipment, that all works. On the back here, this is an anesthesia patient safety checklist. So again, the name, the date, the surgery. The doctor and I will typically then discuss what her ASA status is going to be. So she's a young, healthy cat, blood work was normal. She's going to be a 2. In emergency, we're never gonna see a 1, we're always gonna see a 2, and it's always gonna be an E. So even if it were a healthy puppy with a small laceration, because we're emergency, it's never going to be a 1, it would be a 2E. And that she is a CPR. So these are things that we would also verify the procedure, if they're fasted, if they've received any medications, and then it goes through intra-op, making sure that, well, pre-op that she was hooked up to the machine correctly, intra-op, and then post-op monitoring as well. This is what our monitoring sheets look like for anesthesia. So we can write down the type of fluids that they would be on, their rate. We'll mark with a circle the oxygen rate, with an X the isoflurane percentage. We do monitor their blood pressure, their end-tidal CO2, SpO2, pulse, and resp. I will also mark here how what the airway is patent with. So ET tube, the size. It also has an option for trach tube or mask or chamber induction, and then the position that the patient is in throughout the procedure. Down here is our notes section. Typically that's where I'll write if we give any drugs intra-op, if I'm giving any antibiotics, or if I start to give a bolus, I'm gonna write all those times down there as well. Moving on to our recovery form. It goes every 15 minutes until the patient's fully recovered. That would be that the patient is standing and alert, responsive, all on their own, that vitals are within normal limits. And then there's another checklist with initials. So the time that they're extubated, e-collars made, medications are filled, IV fluids are on and running, heat support if it's needed, and that the case was rounded with the other ICU staff. And then lastly, that our soda lime canister has been either marked down or changed depending on time of usage. While that patient stays, these are our ICU sheets. So it again goes over problem list, FBO, for foreign body obstruction, the doctor's initials, and the overnight technician's initials, CPR DNR status, weight, what catheter size they have, when it was placed, how often it needs to be checked, our 2-day callback code, and then any notes would go in here like allergic reactions, any cautions that we would need to be aware of. And then we have a CRI down here. So in case she needed to have a bag spiked with KCl, or if we were gonna do a fentanyl CRI, we would write those calculations out down there. And then monitoring her vitals every 2 hours, doing those big checks every 6. So that would be temperature, pulse, respiration, and body weight. Mucous membranes, checking the IV catheter, making sure it's still patent, and then her mental status. And then lastly, we have our diagnostic sheet. So this is what would look like if we were going to send out to a lab. And what we would do is we'd go over to the patient medical record on the computer and okay, so I will select the doctor up here that is ordering whichever test it is. And let's say she is ordering a urine to send out. So here would be our drop-down list of the urines that we would select. We would add it. And then from there, our label would print to put on our collection tube. And then that sheet that I just showed you is our send out lab sheet. So we don't have a sheet that we actually check. We have to put it in our computer. We'll make the notes or comments as to why we're sending it out, how long symptoms may have occurred, or what region a sample's from. So if a mass was being sent out, where in the body that was from, why we're sending it out. And then that sheet goes to the lab, one stays here with us. When going over discharges, one of the things that I like to point out is we need to keep the e-collar on. Unless they have an e-collar at home, most times we send them with an e-collar. And I really point that out, that needs to stay on until the sutures have either come out, until it's at 7 to 10 day mark, to prevent them from looking at the incision. And additionally, if there are any other pets in the home, that they should be monitored closely and never left alone together, so that there's no strenuous activity for those sites, or that other animals aren't looking at that incision as well. So kept either confined to a small crate or room when they're not supervised. Short leash walks in and out to use the bathroom only. No running, jumping, playing, or excessive motion in those areas for 7 to 10 days. Depending on the procedure, could be 7 to 14. Getting that incision site wet for that 7 to 14 days. So some sutures that we have used are dissolvable, and so we let them know that they will dissolve once we hit that 14-day mark. You should be fine. There will be a blue suture that typically will fall out over 6 to 8 weeks. Pain medications, so looking at a typical routine spay, mass removal, neuter. A lot of time for our dogs, we're gonna look at carprofen is a good one. If our liver or kidney values are skewed, we might choose Galliprant instead, because that's known to be a bit safer. To highlight the quantity that we're sending them home with, and then when they can start that. So sometimes we give injectable medications like injectable carprofen, and that is only given either the 24-hour dose is either split up into 2 doses every 12 hours, or we give that whole 24-hour dose. So I like to clarify when the next dose is given. I like to highlight that as well. Antibiotics to be started. Sometimes we do try to give the first dose here in clinic. If we're not able to do that, I let them know, and I let them know when they can start that. Other discharge instructions I like to have them follow closely is that their pet was either sedated or under general anesthesia completely. And that slows the GI tract down. And with that, we're not overly concerned, because sometimes it can take about 5 to 7 days for that to reset and everything to move normally. If we have not resumed that, then we want you to give us a call, and then we can go from there. But to not be too concerned, things that we would be concerned is excessive vomiting, excessive diarrhea. And then when they give the first meal at home after the procedure, I like to make them aware that maybe they're not interested in food. They could be nauseous. Almost every patient gets Serenia. We let them know that, and I tell them that it's an anti-nausea medication, that it should help stimulate that appetite, certainly after procedures, but not every pet responds the same way. So by that evening, if we're doing something routine in general practice setting, and they get picked up, discharged, go home, I always tell them for that first night, just keep shallow amounts of water in the bowl. We don't really want them to stand and lap and lap and lap and make themselves sick, since they've gotten IV fluids most of the day. So just to keep it really shallow in the bowl. And then with their meal, give them what you normally would, however, split it up into 2 meals. So give half, wait about 30-45 minutes, make sure they eat it and keep it down okay, and then go ahead and give the other half. I do make them aware of things that they should call us about, so vomiting, lethargy, if the incision site looks infected, so any redness, swelling, discharge, heat to that site, we want to know all about that. And then certainly if you notice any sutures or staples missing, we want you to give us a call. The care is now in their hands. So if they have any questions, they're more than welcome to call. I do ask them, I give them about 3 or 4 opportunities in different ways that I ask to make sure that they don't have any more questions before they leave, so that all of our bases are covered. So sometimes antibiotics are really common with dentals, and like amoxiclav is a very popular one. So we go over instructions with that. If it's a liquid, that it needs to be refrigerated, shake well before using it, should be given with a meal. I do instruct them that if they're having or noticing any signs of pain, to never give them something that we have not prescribed. And if that's the case, or the pain management that we have sent home is not working well, then they need to call us so we can reevaluate and get them a better pain management plan. Other medications that we might send home is gabapentin. One, because it's a great sedative to ensure some healing, and 2, it's a great pain reliever. So I do like to make owners aware of that this is something we're sending home. It is safe to be given with all these medications together. That's another common question. Are these okay to give? And the answer is yes. But that it might have a sedative effect. So sometimes we give a range to owners, which would be 2 to 3 capsules every 8 to 12 hours. And I always tell them, start on the lower end of things and work your way up, because your pet may be more sensitive than your other pet that's been on them. So if that's the case, I might say start with 2 capsules twice a day, and if that doesn't seem strong enough, go up to 3 times a day. And if that's not, then go ahead and give the 3. Sometimes we send home trazodone as well, especially for those post larger incision areas. So spays, mass removals, because we want to keep them calm and quiet. That is strictly just a sedative. It's not going to reduce the pain. However, gabapentin will, carprofen will, and that those are okay to be given together. When it comes to felines and the things that they will need, I always explain to owners, as a feline owner myself, I like to relate to them and let them know, I know it's really hard to keep cats quiet post-op. I wouldn't encourage jumping or jumping up or on or down from surfaces. I wouldn't encourage any form of play, so put the teaser toys away, any other cat toys, catnip, things like that should all be put away until that 14-day mark. If you see a cat looking like they want to jump up, I always tell them, just pick them up and set them on that surface. It's really hard to prevent that otherwise, especially when you're not home. But if that's the case, you see them looking, just go ahead and put them up on that surface. And if they seem like they want to get down, go ahead and just put them down. And then we do worry a lot more about the impact coming down versus going up, but just to do their best with what they have. And then of course I give them their our number of contact. My name is on there, and then our hours. If we're not open from a GP standpoint, there's always a list of the closest emergency clinics that are local to the area. For me, I work at an emergency clinic. However, the general practices that I've worked at before, we're about 45 minutes from any emergency clinic. So we do like to list a couple of those for their convenience in case it's the weekend and we're not open, it's after hours and they have an emergency. We want them to have options. So we do make them aware that animals do still feel pain. I do like to explain to them that naturally they are very stoic and they hide their pain. And that's why we offer these medications, to help them heal, to ensure the best healing. So some people are very, they don't want to give any sedatives, they don't want to give any of those medications. And once I'm able to explain it to them in those terms, they tend to understand a lot better and are okay going forward. Okay. So when restraining for a jugular blood draw, I like to back my patients up in between my legs here and have them sit in a corner so that when they do try to back up, there's nowhere else for them to go. Okay, so now I've got my feet on both sides of him here, and I can use my legs to kind of keep his body still. And then for the rest of the restraint, I'm gonna place my hands under his muzzle like this, place my thumbs around the top of his muzzle. If he has a collar on, I'll hold that up for the restrainer, and just hold him like this. And then whoever's drawing blood will hold off at the bottom of the thoracic inlet. They might direct me to turn one way or another, or turn the head down, but then I can restrain him for that jugular blood draw that way. And then moving on to cephalic, whichever arm the person drawing blood has a preference on, I'm gonna lift that up. And so pretty much mainly using my 4 fingers behind his elbow here and using my thumb to apply pressure on the inside and roll out. And I can keep his head kind of tucked away from the person drawing blood. And then if we're going to a lateral saphenous, come on. You can do that standing or laying down. Regardless, you're going to apply pressure right here on the stifle, and then once the restraint or the person drawing blood can stabilize the vein, but you're going to hold off right here. Okay, so when getting a patient out of a run safely, I'm going to open the door slowly and kind of step to the side because some dogs might be cage aggressive. I'm going to use my slip leash and make a loop big enough to slip around. And we're gonna encourage him to come out. Come on. Good boy. All right, so I'm gonna encourage him back into the run. Come on, this way, right there. Good boy, Tito. I'm gonna stand in front of the door and keep it cracked. I don't wanna be all the way in case he gets really fearful. And I'm gonna go behind his head, loosen up my slip leash here, pull it over the cone. And as I step out, I'm going to slowly close the door. That way everybody,
What is this?
it's okay.
Good boy. Good boy.
We're,
No, my foot needs a little more.
here we go.
Why is it not?
You want it to be tight enough around their neck that they're not going to pull it off, but not so tight that they can't breathe. But you also want to make sure that their muzzle does not extend past the end of it. So here, I know, scary sound. So this would fit him right because when his head's up, our muzzle's not extending past the end of it here. I can fit my 2 fingers, 3 fingers actually under this, but it is secure enough that he can't pull it off. For ones that you have to build and make, typically you'll use a gauze tie to secure that to either the patient itself or to their. I'm going to demonstrate how to obtain a TPR and do a physical exam, pre-anesthetic exam on a canine. So first I'm going to start by auscultating his heart and lungs and getting his temperature. And I'm going to listen to his heart first. And while I listen to his heart, I'm also going to palpate his femoral pulses just to make sure that the pulse quality that I'm feeling is the equivalent of how strong his heartbeat is and that they're synchronous. I've got 100 for a heart rate. His pulse quality does match his heart sounds. Is auscultate his lungs. So there are 9 quadrants to the lung fields. I'm going to listen on both sides for 1 to 2 breath cycles each quadrant. So. All right, breath rate is about 36. Lungs sound clear, so that is all good. Let's get his temperature. (101) even, so that is normal. To do my physical exam, so I'm going to start up at the head and kind of work my way back. So I want to look at his eyes. And I am noting that his right eye towards the lateral canthus on his sclera, he does have a dark mark, like a birthmark. That's it. I'm going to look at his mouth, look at his teeth. We have some mild tartar buildup. Our gum color, pink, less than 2, so nice and healthy. I'm going to palpate, stop it. I'm going to palpate lymph nodes here. Everything feels normal. I'm gonna look at his ears, nice and healthy, pink. No discharge. Same. I'm going to palpate his chest for any masses, abnormalities. We do have some fat pad buildup. Stand. Come on. Stay. No, come on. Let's go. Stay. So now working back, I'm just also going to make sure that we don't have any pain along our spine here. If we were doing surgery and it required him to be in dorsal recumbency, I'd like to know if there is any back pain. Again, palpating pulses on both sides. Good. Feeling for those lymph nodes. Good. Now I'm going to palpate his abdomen for any masses or abnormalities. Bladder is full. And depending on the procedure, I like to do a proprioception test, which he wants no part of. Let me just lift and look. So I did not feel any masses. I did not feel any abnormalities. I didn't see any abnormalities other than we might have some fatty lipomas starting up in here, pretty deep, very early stages. I weighed him before. His weight is 41 kgs. So body condition score wise, he is like a 7.5 out of 9. So I would mark him, being that he is a almost 7-year-old male neutered yellow lab with no pre-existing health conditions. Blood work is unremarkable, and based off physical assessment, his ASA grade would be a 2. And I'm grading him a 2 because I'm really just, he's overweight, and that's the main concerning issue, is when we're overweight, we're at higher risk for anesthetic events to occur. So I would say he's an ASA grade 2. Okay, I will be demonstrating my pre-anesthetic exam on a feline. This is a 4-year-old domestic short hair female spayed cat. So I will start by listening to her heart and lungs. It's 190 for a heart rate. That might indicate that we're a little nervous or anxious, but no murmur. Lungs are nice and clear. Respiration's about 40, so again, we could be nervous. And now we'll do a temp. One of 1.6, so that is all normal. Giving her an ASA risk, blood work's all within normal limits. We have no pre-existing health conditions. I would say she is a risk 1 for an anesthetic. Blood draw, she's going to be holding off the vein there. I am going to place some alcohol onto about where I would be poking. Taking my syringe and needle here, bevel side up. I'm going to place my thumb on the side of his vein to stabilize it. And poking in, drawing back. Okay, so for a jugular blood draw, I'm going to place my thumb at the bottom of his thoracic inlet. I'm going to apply some alcohol to make that vein stand up. And I'm going to palpate where his jug is. And taking the needle bevel side up, so facing me, I'm going to poke pretty much straight in, pull back on the plunger, and that is how you draw blood from a canine lateral saphenous vein. First, I'm going to take my alcohol and put it over the area just to make that vein pop a little more. And I've got my 2 syringes because I will need 6 mL of blood, and my butterfly here. And while she's holding off, I'm going to take my thumb to stabilize the side of the vein. cephalic blood draw on a cat. I have my restrainer, it's going to hold off. I'm going to apply alcohol to make that vein pop up just a little more. And I got my sterile syringe and needle here. And I'm going to place my thumb alongside the cephalic vein. And at about a 10 to 25 degree angle, I'll place that needle, pull back on the plunger, and that I will hold off at the bottom of the thoracic inlet here. My restrainer is going to hold the head. I'm going to apply some alcohol to help that vein stand up, and I'm going to palpate for it. And with my sterile syringe and needle, going to poke and aspirate. Today we'll be demonstrating how to draw blood on a medial saphenous vein for a cat. I do have to give Serenia once I'm done, but I have got my syringes to draw blood and then my tubes set up as well. So first I'm going to start by placing a little bit of alcohol onto this vein here. Thumb here to stabilize along the side of the medial saphenous vein. And it's coming slowly, so we're going to pump a little bit. Okay, so now I'm going to attach my syringe and pull back. When it comes to pre-anesthetic parameters and minimum databases for blood work, we actually don't have a minimum database of what we require before we cut. Typically, when they're coming into an emergency and they do need a procedure, whether or not the blood work is great or not, doesn't decide whether we go forward with the surgery. It may determine whether or not they sit on fluids for 12 hours or 4 hours, depending on the circumstances. Typically, it's going to be, your basic chemistry panel. So we are an Antec utilized company. And so we use a pre-surge beforehand, and that's just the kidney values, your basic, your glucose, your total protein, your ALT. It's just very simple. And a lot of times we change to that based off either the presenting complaint or owner's budget constraints. We also do a CBC and we do a NOVA. So a NOVA here is our electrolytes panel. It's like a GDV or foreign body obstructions. A lot of times we send out our radiographs to a board certified radiologist here, and we follow their recommendation based off that. So GDVs are gonna get surgery anyway. It's to a general practice setting, and a lot of times minimum database was for your puppies and kittens that are getting spayed and neutered. We just want like a Chem 10, which would be IDEX's equivalent to our pre-surge. So basic chemistry panel, and then a CBC. And that's pretty much it. If they're that 6 months of age, we want a heartworm test. Make sure that that's negative before we go ahead with the procedure. If it's not, then typically in a GP setting, we're going to postpone that. We'll treat the heartworm and then come back to that, or refer you to a specialist. In older patients, a Chem 17, which is more comprehensive. So that was the equivalent to our comprehensive panel here. A Chem 17 for IDEX, I know has T4 in it. We do not have T4 in ours. And we typically require that for senior patients. So any patient over the age of 7 and was getting a procedure done. Whether look more in depth at those kidney functions, gallbladder function ratios, liver enzymes, liver function, we want to look at all that, especially erring on the side of caution. So additional diagnostics that might be requested based off of a preliminary pre-anesthetic exam, your blood work for your minimum database could be a fine needle aspirate. So if we're doing a mass removal, sometimes some doctors want to get a couple samples, send those out to a lab, or look at them in-house depending on their comfort level to know what kind of mass we're dealing with. And then helps them understand better what parameters they need to use within surgery, what their surgical margins are going to be. Is it something that I am going to require to get everything out of or not? So it also helps with owners in their concern of lipomas versus something cancer is. So a lot of times we will do that. If a heart murmur is noted, sometimes I know in a GP setting, we would refer to a cardiologist, have that worked up and maintained. Comfort level of for the doctor was not to put them under anesthesia, even if it was for a spay or neuter. They wanted to have that worked up. So typically then the cardiologist would do a ultrasound of the heart. You could do an ECG as well and have looks at those just to see what parameters you're working with as well. If you're having, again, we'll go back to the mass removal. Sometimes we want x-rays beforehand. We want to know, has it metastasized anywhere? You know, do we have spots otherwhere that we need to be concerned in the body than just this one? Could do radiographs for a cystotomy. So if you have, you know, a dog with a history of stones and they're presenting with X, Y, and Z symptoms, you're now moving to a cystotomy as a surgical intervention. Some doctors want an x-ray before and after, just ensuring there's no stones, even though they're going to be cutting that bladder open. So they kind of want an idea of, they might want to work up a thyroid panel on a cat is coming in for a coat hat, and we now are concerned about check a T4. Maybe it means we have to get the thyroid under control before we come back and do the procedure. So those can be additional diagnostics that any doctor might order before you go to surgery. Help them and us as technicians make a better anesthetic plan for medications, treatment, understanding maybe additional risks or complications that could come up, and you're not trying to troubleshoot on the spot through the procedure. One of my favorite things to do is to come up with a really great anesthesia plan. So a multimodal one requiring less gas inhalant during the anesthesia. So for a dystocia, that dystocia is going to get a bupivacaine morphine epidural by myself, and then propofol to induct. And once the puppies are out, moving as quickly as possible. It is doctor dependent whether or not they get hydro during the surgery, a fentanyl, CRI, or methadone. So that is doctor dependent. I like the hydro because you can typically give that in 2 doses. So if you still notice the panting and the trouble getting that respiration and your capnograph to read appropriately, hydro you can get, there's a bigger dose range for that. So you can give 2 doses, 3 doses, you can split that up. And then that will follow them into the post-op. If we're doing an enucleation, I like to do Dextome and Hydro. Hydro provides that pain management. Dextromethorphan provides that analgesia that we need. And then during the procedure, they get propofol to induct. And sometimes, depending on the heart rate, depending on blood pressure, depending on all of those circumstances, we like to add in pain management while in there. So maybe another dose of Hydro or adding in methadone at that point. And then post-op, if blood work is great, they get sometimes a Rimadyl injection. And then right before they get discharged, we give them another Hydro dose to have that on board to get them home. And so multimodal anesthesia is a little of a lot of things to have a better anesthetic procedure and not just be using 1 or 2 things, which can have higher risks if you're just trying to maintain an isoflurane and you have to keep turning your percentage up. If you can add in other injectables and things that are reversible, that is balanced anesthesia, and that makes the anesthetic event that much better for the patient, the technician, and the doctor. Go. Okay, so when logging a controlled substance, I have my patient treatment form here that's to sedate this dog for some radiographs, and the controlled substance we will be using is butorphanol. So doctor wants 0.7 of that. So here in our medical record, his name is Ryder Humphrey, so I'm gonna double click on that name. And then underneath our RAD abdominal study, because that is what we're doing it under, we're gonna check mark sedation. And then there's a drop down that's gonna come up. We are not gonna place an IV catheter. So he is going to get sedated with dexdomitor and butorphanol. So I checked all of those. We also check our antecedent, and anything that gets sedated also gets Cerenia, so that's under meropitant. So he is getting 3.5 mils of Cerenia. Dex is 0.4. Butorphanol is 0.7. And then we also draw up our antecedent or atipamezole at the same time, so 0.4 of that. Apply. It's going to ask me where I want our controlled log label to print to. I will have it print to lab. let's go grab that. Find our corresponding controlled logbooks. So butorphanol. I'm gonna go to the next page here. So in this spot, this is gonna be the patient sticker. So it's got the patient's name, the date, the client's name, address, the doctor, the prescribing doctor of this, the amount, and the drug. So this goes in here. It also has butorphanol, the strength 10 mg per mil, that it's injectable, and then the container ID, which is 24/6. And then I will also handwrite in the date. And then doctor's initials, so AW. That I am the dispenser, so I'm gonna do that. And then Jacqueline behind the camera will be my witness, and she will initial that, but I will be dispensing 0.7 mils of butorphanol, and that is how you log a controlled substance in our isoflurane vaporizer. This is what's going to control the percentage of gas inhalant my patient receives, going all the way up to 5% down to 0. So that you push down this knob and you turn it to whatever percentage you think is appropriate. And once you hear that click, you know it's all the way off, but you do have to push it in order to turn and make that adjustment. We have this fill line right here. So there's 2 arrows. In between there is where you want your isoflurane to be. It's not fun being in a procedure and running out of ISO, so that is something that I personally like to check off and always check before I start any anesthetic procedure. I also want to note that right here, next at the bottom of the vaporizer, bottom left, is where you screw on and off for your isoflurane to get filled to. So that's where you actually put it in that reservoir there. This is our flow meter for our oxygen. Hang it up. You're just gonna see that ball float, and that is going to be your liters that they receive for oxygen. So that is completely where you control. This is your oxygen flush valve. Never want to have that on when, or use that when you have a patient intubated. By doing that, you could actually expand their lungs to a point that they burst. Vaporizer hooks up right into here. This is going into our reservoir bag. This is going to hold our oxygen and our vaporizer, where they inhale from here. So it's going to go down. This is a long pediatric tube. It's going to go down the tube. Patient's going to receive it. When they exhale, it's going to come in through here and back into our scavenging unit. Turn off my isoflurane from a anesthetic procedure. I do like to empty my bag, flush it, disconnect the patient, of course, flush the bag to empty it from the ISO, and have them breathe in only oxygen for about 10 to 15 minutes post-op, if they'll allow it. And again, I also like to start titrating down my isoflurane as I know the doctor's going to be wrapping up. This is our CO2 or canister or soda lime, soda sorb. We keep a checklist attached to every anesthesia machine off the hours of usage. So it either gets changed every 7 days or every 12 hours of use. Gets dumped to the trash, and we refill it to the line in there. We also mark who refilled it or changed it and the date, so we know when it's been a week, when it's time to be changed. This is going to be our emergency pump off valve. So you turn this all the way down, and by allowing this bag to fill, their lungs will be able to expand. They won't be able to exhale properly. We always make sure that we leave this open, and then we never have to worry about that. This is our pressure gauge. So this is how you leak test the machine. This is also how you know you're giving an adequate breath. If I need to breathe for my patient, get them down a little faster, or get them deeper really quickly. So turning on our oxygen, covering the hole here, we close it, we hold down, hit our oxygen flush valve, and this is automatically going to hold at 20. So it might go past, but what you want it to do is hold it at 20 for about 30 seconds. And then if it passes, you know that there is no leak. If it does not pass, then you'll need to identify the leak. Sometimes it's best used with Windex, spraying it on certain areas of the tubing. Knowing your machine, there is a, you want to check these to make sure that they're not sticking or leaking. So you'll spray around here, and then checking the bag too as well. So we'll pressure check this for right now. So I'm going to turn our oxygen on. I'm going to hold our emergency pop-off valve down. I'm gonna fill the bag. And it needs to hold for about 30 seconds in order to be good. So this did pass our pressure check, our leak test, and so this machine would be ready to be used. On the back of our exhalation here, this blue tube is connected to our scavenging system. Here we can hold an F-air canister, which is really good for our non-rebreather bags. We have an active scavenging system here. So this blue tube here that is connected all the way down here to our discharge canister, that is our scavenging source. This green line is our oxygen source. Masks, so you can, if needed, induce anesthesia with a mask or hold oxygen. So depending on the patient or the stress level that they are, if we want to give them some flow by, we might take the gasket off of this so that they can just hold their face in there, maybe pant, but also receive some oxygen. If we're trying to induce, you put the gasket on, and then it'll create a seal around their muzzle. Sizes of masks. This is a pediatric size connector. This piece goes to our exhalation. This helps get rid of that humidification that when they exhale. So it helps our tubes not get as wet as quickly and dry a bit faster, which is nice. So indicator for using this size tube, you're going to be looking at a patient that weighs about 5 to 7 kgs. They would get that pediatric tube. Non-rebreather, you want patients under 10 pounds or 5 kgs. This is what our non-rebreather looks like. So, okay, so with our non-rebreathing system, which is also, I believe, referred to as a modified Reese system, what we do is a couple things. So this part right here is going to be our pop-off valve. This is how we open and close it and give a breath. We'll put our rebreathing bag on there. This blue part that we always leave attached to our non-rebreathers here, this would hook up to our scavenging system. And a lot of times we'll hook this up to an F-air canister because the scavenging system for animals this size that requires this is typically too strong and pulls a lot of it away before they can actually receive it. And so we'll hook this up to an F-air canister. And that would be our passive scavenging. And then this part would hook directly into their ET tube. And then this part, this long, small, clear rubber hose with this black end here is going to hook up right on this end actually where our fresh gas outlet is. So we have where our oxygen and our gas meet essentially gets hooked up into that. So we have our adult tubes. So this is gonna be anything over 20 pounds is gonna get a system like this. So again, ET tube. This is going to hook up to our exhalation valve, and this will hook up to our inhalation, but more appropriate for those larger animals. Okay, lastly is our oxygen system. So we actually make our own oxygen here. Okay, so this door is actually locked, but that door holds 4 backup oxygen tanks like these, just in case we were to ever run out of oxygen. And we have, I believe we have like 5 different compressors up here, 2 oxygen tanks, and then for those oxygen tanks, we have 1 and 2 that control those and how much air is getting put in, that it's getting stored properly, that it's coming out properly. We also have nitrous oxide here. End tidal, ways that I know that I've intubated properly are because one, we are getting a end tidal reading. If we got a 0, that would mean that we are in the esophagus. The other thing too is that we want to make sure we're not inspiring any CO2 that would be abnormal and that we're only expiring. So that and correct placement, that the cup is inflated correctly, is you can palpate on the thoracic inlet there, or by seeing the fogging of the tube, holding up your hand to it if it were not attached. I'm going to hook up our SpO2, which monitors the oxygen circulating in our blood. Next, I'm going to hook up our ECG leads to monitor the heart rate properly. For the left side, black is on the left forelimb. Right is on the red is on the left rear limb, so smoke over fire, and then right goes on right arm. Those going. We have our esophageal thermometer to ensure that our temperature stays normal. I'm going to lube the eyes. And lastly, we're going to hook up our blood pressure cuff because we do want to monitor that for any hypotension, hypertension throughout the procedure. That can indicate if we are too deep in an anesthetic plane or too light, or if we have sufficient blood loss. So that is how you would set up, intubate, and monitor your patient. I'm going to be performing a gastric intubation. This patient is here not for a GDV, we don't think, but severe ileus instead. So we will need to pass this to decompress his stomach. So the way you measure that is from the last rib to the back of the incisors. And we're going to mark that. I have my lavage bucket set up as well. And to be extra prepared, I have a puppy pad down as well as the part that will connect to that. So I'm going to place some sterile lube at the end of this OG tube. And not a whole lot, but just enough. And because we have the ET tube in, there's only one place for us to go. And I'm not having a hard time passing it. And we should be almost in right there. So now I will wait for the doctor and we will start to flush his stomach and decompress that. And that's how you do a gastric intubation. Hi, my name is Faith and I'm here with my preceptor Cass, who is an LVT at the emergency center that I work at. And so you might see her pop in and out of videos from this point on, given the venipuncture and all the other tasks required. Okay, girl. Remove all the hair. I'm going to scrub 3 times. So once with my chlorhexidine and then rinsing with alcohol. This is the alcohol rinse. And doing that target or bullseye motion. All right, so now I'm going to stabilize my thumb along the side of her cephalic vein. Okay, just a poke, it's okay. Good girl.
Good girl.
All right, now that I have that flash, I'm going to continue to advance.
Okay,
going to hold
easy.
pressure.
Good job, honey.
All right, so I'm going to secure this in place with my first 1/2-inch piece of tape, sticky side up, around the hub, and go around the leg. Then I will attach my T-port.
Stressful.
No, honey. It's okay. And while hanging on to the hub of the catheter, I'm going to screw that into place, and then to make sure it is patent, I'm going to flush. And we don't see any blowing. We can feel it high up in the leg, so we know that that vein is patent, and that would be how you place an IV catheter. Now I'm going to secure it with my 1-inch piece of tape that's torn in half. And then as far as bandaging goes here at BCA Emergency, we don't bandage the leg because if they are admitted, she's here for seizures, so she has the potential to be. We check their catheter sites every 24 hours and then ensure its patency every 6. So we only use our tape to secure that way. Okay, so when placing a lateral saphenous catheter, I'm going to start by clipping the area. And if he were a patient here getting hospitalized, I would actually shave all the way around so that our tape stays. But now that that area has been shaved, I'm going to do my 3 scrubs. So I will start with chlorhexidine and then rinse with alcohol. And then you'll do it in your circle or bullseye motion. So starting on the inside and going out. So I've got my heparinized T-port flush here. I've also got 2 catheters, and then I've got my tape up there. I always like to keep an extra catheter on hand, so my restrainer is going to hold off. And bevel side up for the catheter. I don't want to touch the area that I've just scrubbed. However, I am going to stabilize the vein right next to it with my thumb here. Okay. And now I'm going to connect my flush. I'm going to flush to make sure that it's patent. Now I'm going to take my 1/2 inch piece of tape facing sticky side up and place that down at the hub of the catheter. We'll wrap it once around the leg. And I'm going to really secure that into place. Now I'm going to take my 1-inch piece of tape that's perforated there. I'm going to place it under. Now I have a piece of vet wrap, so we will place that under the T-port as well. And then lastly, I'm going to make a stress loop with a 1/2 inch piece of tape for my T-port here. So I'm going to make sure that I clamp this. And I'm going to take this, I'm going to wrap it around here. And then on top of our bandage here. After taping this into place, I'm going to unclamp just to make sure that we're still patent. And detach, clamp our T-port first, detach our heparinized flush, and then he would be all set to be hooked up to fluids. Okay, so now I'm going to demonstrate how to give a sub-Q injection. Here I have my Serenia, 1 mg per kg dose. So I'm going to pull up on the skin. There's going to be a little tint there. I'm going to go in, draw back, get negative pressure, and inject. And that's it. All right, this is Jackie. She's one of my preceptors, so you'll see her in and out throughout the videos now. I'm gonna demonstrate giving an IM injection. So I'm gonna place my thumb here, right over the femur, isolating this muscle. I'm gonna poke in, aspirate, make sure I don't get any blood back. All done. And that is how you give an IM injection. Hold off his cephalic vein right behind the elbow. I'm gonna pick it up and just do a little bit of alcohol to make that vein stand. And bevel side up, so needle facing me. I'm going to put my thumb next to the vein just to stabilize it. I'm going to draw back, make sure that I got blood, and she's gonna let go. I'm going to inject. We're going to induce anesthesia for our friend here. I've got propofol and a flush. The first thing I want to do is flush the IV catheter to make sure that it's patent so that propofol does not go outside the line. Legit. It's good. I have prepped my ET tubes. So this dog is over 20 kgs. The formula says above 20 kgs. They're going to be above a size 11 ET tube. However, sometimes they're patient dependent. So I grabbed an 11, a 12, and a 13. They sat inflated while I pre-medded my patient and came back. None of them had deflated, so I knew that they were good there. We also leak test these every time we wash them by inflating them, sitting them in a tub of water, and making sure that we don't see any bubbles. Sterile lube for when I place those. And our to effect dose for this guy is 26 mils of propofol. So propofol is given IV slowly. If given rapidly, can cause apnea. It is fairly short acting, so there's different doses for induction rate versus twilight. I'm gonna flush that through and see how that goes. All right, so I have given 16 mils of propofol. I'm going to flush the rest through the IV catheter. Clamp the T-port. All right, so I'm going to take my tube, measure to the base of the thoracic inlet without touching the ET tube to the fur itself and contaminating it, to measure right to the incisors, and out there is where we're going to want to make sure that that ends. I'm just placing a small amount of sterile lubricant onto where the ET tube would inflate, and I've got my laryngoscope. So with my non-dominant hand, I'm going to pull the tongue out and forward. I'm going to visualize the glottis, epiglottis, larynx, and pull down the epiglottis. And I'm passing it through the vocal cords. Closing, now I've got my gauze tied, where I will secure it to the tube. All right. Inflator. I'm going to inflate. Field stethoscope, you want to use one that's appropriate for the size of your patient, which this will be long enough. Because you're going to want to be able to hear proper lung sounds and the heart. So this will lie in the esophagus right next to the heart. You can use sterile lube just a little bit here to help pass it. You can keep. And there's only one place for this to go with your ET tube in. So it's not going to go down the trachea. It's only going to go into the esophagus. You can, a couple different ways you can measure to know that it's long enough. You can measure to the where the costochondral joint meets the ribs, which is what you would base your chest compressions on if you were doing CPR. So and then you're able to monitor directly to the heart and lungs without trying to reach under and breaking the sterile field. Okay, so I'm gonna palpate and express her bladder. Okay, so since we're shaving for the neuter, I'm gonna shave up to the umbilicus and all the margins up to the sides here and the testicles and just below them. So, and then I'll get yeah. Right? Like, doing the house first. Yeah. Okay. Okay. Alright, what's up? Okay. Okay, so I'm going to start by flushing the prepuce with a dilute chlorhexidine solution. So I've got my syringe here. I'm going to fill it up. Move it around. And then get all of that back out. And I'll do it one more time. It's a dirty scrub out here, and we'll do 3 inside the surgery suite. So I'm going to start with my dilute chlorhex, and I'm going to do, again, that bullseye motion, being very considerate that I do not cross-contaminate where I've already gone, and then rinsing with my alcohol.
Not that I don't think it's appropriate. I just didn't know you would have.
Good.
Oh, sorry. Okay. Ready?
Esophageal founder. And then still using the same solution, chlorhexidine, and rinsing with alcohol. And this is our final sterile scrub. Okay, I'll stop it.
drape.
Whatever is hydrolyzed, so if they're allergic to chicken, then maybe don't go with hydrolyzed chicken. Just in case. So that's stuck as the salmon for vegetarian.
Yeah, what is just a vegetarian? Because he's on salmon.
Oh, this is gonna be interesting.
But if she's going to do a food trial, she can.
I know, yeah, we're going to talk to her about that. Because I don't think I get understood.
The chicken food, those food from the barn.
Yeah, that's the other thing. Cat food, we can't
Cat
get into
food.
cat food. Yeah, he's been crappy like he's falling in the middle of the night. He's like in his butt. Constantly.
Sorry, I hope I didn't. It's gurgling a little bit. I hope I didn't make it mad.
Nope, you're all right.
She's getting really frustrated. I was like, I think I know what your problem is, but she didn't see all and we recommended it. So we're looking at different foods. I mean, from that one because it's cheaper on the period of professionals if I were.
Cutting.
I think it's the biggest bag that they.
Thank you, Jackie.
Yeah. As far as the hydrolyzed goes. I was just confused because, yeah, I mean, the ones we saw here don't, at least on the front of the bag doesn't say if they have a protein or what. So
Yeah,
I guess
bread
it's
and
just
soy,
okay.
pills, CB's chicken.
Oh, is it?
Yeah. Blue Buffalo has a hydrolyzed salmon.
Come on now.
Salmon.
How's you?
So,
A large, deep-chested, keel-chested dog, your hand placement is going to be lower to the chest. If you have a round chested dog like a bulldog, a Frenchie, a beagle, instead of having them on their side, you want to have them on their back, placing your hands right over the center. Otherwise, let's say we have a Labrador that we're doing chest compressions on, where that costochondral joint, when it comes up, where it meets on the ribs, that's approximately where the heart's going to be. So again, we're aiming for 120 beats per minute, an end tidal of at least 12, and then checking every 2 minutes to see if we have spontaneous circulation or if we need to continue, give more drugs, things like that. So for the chest compressions part, our head is always going to be facing the machine of our oxygen or anesthetic machine. Most times they are already intubated and hooking up to oxygen. So you can breathe for them through your oxygen bag hookup. Left hand and put it, I'm going to place it, my right hand on top. I'm going to interlock my fingers and I'm going to do chest compressions. So you want to do about 2/3 of the chest width going down, keeping your elbows locked because you are really using your core and back for this. You should be using your arms. So core and back. You can deliver room oxygen, I believe up to 21% with a face mask in an ambu bag. So again, that gasket to seal, and then every 6 seconds, because you're trying to get, every 10 seconds, you're trying to get 6 breaths in a minute. So if we were intubated and we weren't using a face mask, there's our endotracheal tube. This could hook directly up to that. Again, delivering room air. So now we're intubated, and that's how we're giving our breath with an endotracheal. Finger prep. Going underneath the nails, which are very short, so there's not much to get out under there. So every surface that I scrub on my hands will need to be scrubbed 10 times. So the fingernails. All right, and now starting with the outer of my index finger, I'm going to work each surface all the way to the end of my pinky 10 times. Starting with the outer surface of starting with the inner surface of the outer surface of my index finger, I'm going to work all the surfaces 10 times. Now to the outer portion of the pinky. Now doing the palm of my hand 10 times. Lifting up each finger. Doing my thumb now. Now doing the outer surface of my thumb. Now doing the back of my hand down to my wrist. Okay, now we're going to scrub all the way up to my elbow 10 times, back and forth 10 times. So. All right, onto this hand. So fingertips back and forth 10 times. All right, and then repeat. All right, now to the palm. Now to the back of the hand with the thumb. And then form up to the elbows. All right, now rinse.
Go.
Hustle utensils here. Nope. No. Stay Clover. Stop. Relax. Stay. Good girl, Clover. Good girl. Good job, Miss Clover. Good girl, Clover. Good girl, honey. Good girl. Stay, baby. Walk the Clover. Look, here. Stop. Stay. Okay, then. Clover. Stop that. Hang on, girl. Hi, hold on. Gross. That was a good size one. Okay. No. Girl, you're gonna pop up your harness. You're full. For starters, it's a little loose for you. Pop out the Clover. Stay. Okay, let's try this again. What are you doing?
You can probably stop it to time you.
Okay.
Hey, hi, buddy. Nice man.
Yep, going backwards. Good job.
We should have 30 gauze.
Thank you.
15.
You can go ahead.
Maybe a new pair of gloves.
Okay. That's okay.
We're gonna give you the babies and medicine balls. And then the baby forceps. Yep. And then if you want a blot. Ah, you're good.
The duties and responsibilities of a sterile technician are, there's a lot of things that they're tackling. So that is tissue handling, making sure that you are maintaining hemostasis, making sure that your tissues that you are handling stay nice and moist and don't get overly dry, but also maybe blotting some of that blood out of the way for the doctor, or using cautery if they need it. Handing them instruments, doing the instrument count and setup for the doctor to make things more accessible to them, passing off the instruments. Sometimes that can be ligation, irrigation, cautery, your scalpel blade and handle, and understanding proper techniques in passing those. So additionally, you are essentially a second set of hands to the doctor. So if you are doing a big surgery, if you are doing an enterotomy, sometimes they need an extra set of hands that are sterile to hold things out of the way if retractors are not able to be used due to body size or convenience of that location. So sometimes you're going to be stuck holding the organs, making sure that they do not break that sterile field. And then also identifying types of suture and what's needed. In some states, a veterinary nurse is able to close the subacute level tissue for the doctor. So being able to identify what suture is needed for internal sutures, what's appropriate for external sutures, are they dissolvable, will they need to be removed? Identifying patterns for different injuries, what type of suture pattern is going to be most appropriate for the circumstance that you are using it in. And then additionally, if somebody were to break the sterile field, the most appropriate thing to do is if it's an instrument, if you do not have a backup that's already sterilized, or you cannot call somebody else in to get that for you, you are going to flash sterilize that and be able to reuse that. If you were to pop a glove, the best thing to do is to notify the doctor right immediately. You're going to back out of the surgical field, and you're going to need to restart your process essentially in getting sterile again, getting your new gloves on.
Go. Hi, I'm Cassandra Beekler. I'm an LVT at the VCA Veterinary Specialty and Emergency Center of Kalamazoo, and I am preceptor for Faith Jordan. I am recording this video to attest to the fact that I have seen Faith do anesthesia and induction on spays, canine spays. We have not unfortunately had the opportunity to do any recently, but she has done several in the past, and they have all gone very well, so I am very confident in her proficiency.
So when cleaning your surgery suite, do as best as possible to start in the center and then work your way out. So that starts with the table, the lights, and then your equipment's floors, counter surfaces, things like that. And I will be using my Kenasol to spray down and clean everything today. lastly, you want to check your tray underneath your surgical table. I like to clean once a week, and that is on Thursday since that's our last surgery day here. So that will be cleaned on Thursday. Okay, in cleaning your instruments that are soiled from surgery, you're going to make a wash basin that has distilled water in it with diluted Humusol, which is what this is, and you're going to want to pre-soak them in that. We do this because once the blood dries, especially with all the grooves on all these instruments, it's really hard to get out. So the other thing that you can do with your brushes and with your instruments is you have these brushes. You've got soft bristle and wire bristle to help scrub off that debris. So because of the high iron content in water, we don't want to use normal tap water. We want to use the distilled water, preferably that's cold, especially when you're rinsing, because hot water can aid in those proteins that blood carries. So, and make sure you get all aspects of the instrument cleaned off, all that blood and tissue cleaned off. And then I will show you how to rinse. I'm going to fill up my basin with the distilled water to rinse each instrument now that the basin has been rinsed out of the diluted Humusol solution. So I'm going to fill this up and then we'll rinse our instruments. Okay, so now I'm going to set these on a lint-free, dry surface. So as I continue to rinse them. So now I'm going to transfer my instruments because they've been decontaminated into the ultrasonic cleaner. And we have a pre-mixed solution already with distilled water and the ultrasonic cleaning solution, which has enzymes in it to really break up and eat up that debris. So fill this up in the ultrasonic cleanser, turn it on so that the water can get warm, and then I will set a timer for probably about 6 out of the ultrasonic cleaner to let them dry. Again, leaving lock boxes open. All right, and then we're gonna spray our joints with the lubricant. So that's this part. Let that dry. General surgery packs or spay packs, we have 30 gauze in there. That is what we put our instruments through. So you get them all lined up here. We want to leave the lock boxes unlocked because the more you keep them locked, the quicker they wear down. So we do leave them unlocked, other than the one with the towel clamp. All right, so let those down. So I'll kind of get them as flat as possible. The top there. And we'll pull this up to tuck it against the kidney bowl. And then our forceps in the kidney bowl, and then our 4 towel clamps go at the bottom down here. Now in accordion style fold, we put a paper drape in. This has a small sheet drape, fabric drape, with the edge folded, accordion style. And then same with our towel, folded accordion style. Sterile indicator strip that goes in there so that when they open the pack and that's dark, they know that it's been sterilized and it's okay to use it. You want to have it as tight as possible to ensure sterility. So smoothing everything out and then over. And then this, when it hangs over the edge, you don't really want them overlapping. So you'll accordion style fold that in until you've got it lined up with that first fold in. And then we'll do the same thing over here. And then taking the bottom here, folding it up, flipping, and then there's a little pocket from where you folded. You're going to push that in, being sure to leave a tab out to pull. And then you will take your piece of sterile indicator strip that's got the name of the pack, the initials, and the date that it was autoclaved, and seal it like that. And then once you're done folding it, you should have something that looks like this. Start by, in a lint-free area, placing the gown on the table face up. I'm going to take your sleeves and crisscross them at the wrist. Up at the collar. You want to also make sure that you keep your neck ties out, because that is going to be the point where typically the doctor will grab. So you'll take one side and you can fold so that they meet in the middle. And then you can, here is where you can pinch. So you will have it on top of each other. And then again, accordion, fold in, smooth it out. Accordion, fold in, smooth it out. So now you're going to accordion fold it. So that'll be taking the back end and working up towards the neck. Making sure that it's not too thick when you fold it. You're going to take your sterility strip indicator and place it in the middle of the gown. On top of the gown, you are then going to add your huck towels. You can start by folding this in half again, and then accordion style. And then making sure to fold one corner back, like so. That way, that is the corner that they can pick it up from. And as tight as possible, I'm gonna go in, fold back. This is sticking out, so, oh, there we go. By adjusting it, it's not. So now we're going to take this corner, fold it in on top, straighten everything out, fold back so we're not overlapping. Fold over. And again, it's always going to be an accordion style fold, pretty much with whatever you're doing. And then up, tucking it in. So this layer does not get taped yet. This is your tab so that once the sterile dirty area is open before scrubbing, this is still sterile and you can pull that tab to open. So in the center, and then you're going to repeat those same steps. So over, tucking it as tightly as possible. So again, leaving that tab there. And then the final step is your tape. So I leave a tab to pull, to tear. This tape will change color once the autoclave has sterilized it. And then with your Sharpie, you will write what it is, the date. So the date, surgery gown, with 1 hub towel, and then my initials. 2 of our autoclaves here at VCA Emergency and Specialty Center. They are our steam sterilizers. So how these work is that you put in distilled water through here, and there's a gauge right here along the sides that have a green or red indicating marker. So that would be when your distilled water is getting low and you would need to refill it. The way that works is once it's turned on, the distilled water goes to the bottom, it electrically gets heated, and then that steam is then pushed out through vents and into the autoclave. And then once the cycle is complete, the water condenses back down and, or the steam condenses back down and it goes back into water. Temperatures for these are 250 to 270 degrees Fahrenheit. Typically, the PSI for the sterilization is going to be 15 to 27 PSI, and then that allows sterilization to occur in about 3 to 15 minutes. Typically, these get ran on a half-an-hour cycle. So that allows for that heat and steam to build up, to condense back down, and then allows time to vent. So when these are done running, okay, that's shut all the way. When they're done running, these will automatically pop open just enough to let the rest of that steam come out. They're very hot, so when even this does break open, we still like to give it another 15 minutes after the steam has settled and we don't see any condensation anymore, because the packs coming out are really hot, so you have to be cautious of that. When packing these, and these should get repacked, you can have multiple things in here, but you don't want your pouches or packs to be touching the walls of the autoclave. That is kind of counterproductive. It doesn't allow the steam to fully penetrate into the center and actually sterilize the things that it needs to. So you can have multiple things in there. You can do even your surgery packs, like your gown or your general surgery pack, spay pack, neuter pack, with the cloth material. But again, you really don't want these to be up against the wall, because that doesn't allow for the steam to penetrate deep into the center where it needs to be. We're going to pack this top autoclave here. I've got a few things here. Everything that we pack, even if it goes in a pouch, it goes in one at first, and then it goes into a smaller one, and then into a bigger one. That way, when we hand it to doctor in surgery, we can open it up, let it drop, or actually physically let them pull it out, because that's still sterile if we are not. So for this, so these pouches have sterile indicator strips, or not strips, they have markers here. So those will change color once they have been properly sterilized. So you don't want to pile them like this, but rather than standing them up is better. So my packs are physically not touching the walls. We have the edges here that are touching the sides. That's okay. And we're allowing for some ventilation space in between them. And of the things that I have that need to be sterilized, that is all that I'm going to put in there, because this pack is going to be way too big to add in. And this is for our orthopedic surgeon, all of these are. So that is not going to make it in, so that we will save for a separate autoclave. The nice thing about these is, so once I push that in, it's locked. We can mark how we're going to run the cycle. So like this is indicating we need to perform maintenance. But we can do unwrapped for unwrapped pieces, or hand pieces for like dentals. However, those typically do get wrapped back into a pouch or a kit of some sort, and then get that drape wrapped around it and sterilized with the sterile indicator tape. So we can actually select pouches, because they're in pouches, it tells us that it's going to be a fast vent dry for 30 minutes, that they will be sterilized at 270 degrees Fahrenheit, and that happens in 4 minutes. So the rest is building that time up in pressure to get to that, and then the actual sterilization happens at that degree for 4 minutes, and then the rest will be that 30-minute fast vent dry where it pops open just a little bit and allows all that extra steam and condensation to come out rather than stay in the packs. So, and again, that's something we want to make sure, like if we're seeing watermarks on our cloth surgical packs or condensation inside those packs, the autoclave was probably packed too tightly, and those should be undone and re-sterilized again. The things inside could still be wet and not dry properly. So we can do that. For packs, if we were doing wrapped packs, that says it's gonna happen at 250 degrees and it's gonna last for 30 minutes. So that's gonna be the lower end of those two temperatures or that range that I gave earlier. So it'll take however long it does to get up to 250. It will sterilize for 30 minutes. Those are going to be your bigger, bulkier cloth grade packs. And so these would be sterilized at a lower temperature for a longer period of time to make sure that they penetrate deeply and are properly sterilized. Couple ways that I know that these have been sterilized is we'll start with the tape. So as earlier, this is how our indicator tape for an autoclave, which is our steam sterilizer, packs that go in and need to be taped around. This is what it looks like before. This is what it looks like after. That color change should occur. Additionally, in our packs like this, typically we keep these on our wet tables for the technicians if we're prepping a dirty procedure out there. If it's like a clip and clean wound, we keep these out there for us. So as shown you earlier, I believe the two colors were pink and blue, and it was a pretty bright pink and blue. Now these two colors, this color change, this was blue originally, it's a dark brown. So that means it's properly sterilized. On this side, it says that it's changed color, again, properly sterilized. So I know that this is good to go. On another one, which wasn't me, this I probably will, I will rewrap it. This is one of our mini lac packs that we use in the ER. There should be a sterile indicator strip, like so, in there. So this should be on top so that when I get this out for the doctor or the doctor opens this up before they're ready to put their sterile gloves on, this should be dark, noting the change color, that this is not just trusting the indicator tabs up here, but knowing that everything inside is properly sterilized. This should be on top of that bowl in there as well. So I will rewrap this to get that done. But that is how you know that your packs, your pouches have been properly sterilized, and that is how you would use your autoclave. Maintenance wise on your autoclaves, at least daily, you should be wiping everything down with a soft cloth and some water and just keeping it generally clean. These, like I said, will give you a reminder to perform your monthly maintenance every 28 days. And there's a couple different things you do. You have to follow, number one, the manufacturer's recommendations, but you will take your distilled water chamber, you will empty this completely, and then you will add where you put your packs to sterilize. You'll add 1 ounce of the speed cleaner, autoclave speed cleaner, and then go refill this after removing the old distilled water. You'll fill that back up. You will place it on a pouches cycle and then stop it when it gets to the dry cycle. That way you don't need to go through that. And then you'll open it back up. You'll repeat that by emptying the water chamber and then filling it back up again and doing the unwrapped cycle, and then stopping it when it gets to the dry cycle, repeating that same step, and then for packs. Afterwards, once that's all done, you'll remove your trays out. You will clean those thoroughly. We don't like to use steel wire brushes on that, and again, we like to use distilled water because Otherwise, tap water with the enzymes and that can cause them to rust quickly. There are filters back here that you should pull out and clean those or inspect them to make sure they do not need to be replaced. Wiping down the walls, the top, the bottom, want to wipe off the inside, and then keeping this gasket here clean, which is this orange part on the inside. That helps seal to keep everything in while it's sterilizing. And then, you know, getting into the crevices, making sure that monthly, this has been completely cleaned versus just your daily wipe down from daily use. So that is how you maintain your autoclave, and oftentimes troubleshooting if it's not working well, if it's not sterilizing well. That should be the first place you start, is when was the last time it was cleaned, how was it cleaned, were things put back properly, and that is how you would do your maintenance function on your steam sterilizer. So today I'm going to be removing staples from a C-section spay line that was done 12 days ago. I know that these are ready to be removed because we're not having any purulent discharge, any redness, swelling, any new fresh bleeding. Everything is pretty scabbed over, and our incision line is closed as well. So, and given that we are 12 days post-op, the typical time to remove them is 10 to 14 days. So I'm going to start down here. And that is how you remove staples.